I am calling the meeting to order. I note there is a quorum, and I also want to welcome Sandy Walitsky. Wave Sandy. There. She is replacing Eric Gold from the AG's office. As you saw from the material that was mailed out, we have a very full agenda, and CHIA has been very busy with lots of reports, lots of work on the APCD, lots of work on COVID efforts, et cetera. Today, most of the attention is going to be on the performance of the healthcare system report. You'll notice a couple of other things in the material that was mailed out. We have a copy of the provider price variation reports. That is for your information to save another email because it's coming out tomorrow. It is not on the agenda for today. And you also saw attached media activity and some statements on the report, which was actually very helpful, Ray. Thank you for sending that out. I think most of us may not have seen all of that. So that was great. Finally, at the end of the meeting, at our last meeting, we asked for a discussion of research, and that will occur in June, but Ray is going to tee it up today. So the first order of business is to approve the minutes of the December 2nd meeting. Are there any corrections, changes, or comments?
So moved.
Thank you. I now need to do a roll call according to the rules of Zoom. I will get my glasses to make sure I don't forget anybody. Please unmute yourself and say yay or nay. Rob Birmingham.
Yay.
Ray Campbell.
Yay.
Myself, yes. Bill Geary.
Yay.
Thank you. EI, Phil.
Hiya.
Hiya. Sorry, I do that every time to you. I'm sorry.
That's okay. Here.
Yay or nay?
Oh, sorry. Yes, yay.
Great. Lauren Peters, I think you just joined. Yep. Lauren, are you there?
Yes, aye. Thanks.
Okay. Niels?
Yay.
Cassandra?
Yay.
Great. Meredith?
Yay.
David?
Aye.
Terrific. They are approved, and I now get to turn it over to you, Ray, who will be facilitating the rest of the meeting.
Thank you so much, Chair Donahue. I appreciate that. Welcome, everyone. Good to see everyone, and looking forward to today's session. As the chair indicated, it's a very full one and a lot of very interesting materials. So a lot has been going on. Alex, can we switch to presentation view? There we go. Okay. So we'll be using the slide deck, and let's go through to the agenda. This is, as I indicated, I'll be doing an executive director's report first, and then followed by two kind of extended conversations. The first on CHIA's annual report. The timing is always that or historically, and we'll talk more about timing when we get to it, but that we release this in the fall. But then the Oversight Council typically doesn't meet until a few months afterwards. And so we've never really had a chance for a full discussion around the annual report when it's fresh. And so we're going to have a good discussion about that today. And then we'll have a presentation from the Health Policy Commission as part of an ongoing series we want to do of having CHIA data users talk about their uses of our data. Next slide, please. Okay, so just starting off with the finance update, kind of as always, CHIA's finances, well, first we pay great attention to them, and our finances are in good shape. Our finances are somewhat unusual because of the kind of the continued effects of Chapter 115, although the current fiscal year, fiscal 21, is the final year in which CHIA is making curative payments. And so we work, as we do every year, closely with the Executive Office for Administration and Finance to manage our finances. We will again in fiscal 21 use some capital as part of our overall plan for balancing the budget and making our curative payments, but everything is looking very good on the fiscal 21 front. Fiscal 22, the mid-year review process recently concluded, and CHIA looks like we'll be in very good shape for fiscal 22 in terms of the resources we need for all of the work that we're doing, the things we'll be talking about today. So from a financial perspective, CHIA is doing very well. I mean, the details of it are get somewhat, it's the intricacies of state finance. I can answer any questions that people have. Let me turn it over to Cassandra first to see if she has any additional comments to make about CHIA's finances, but they're, I would describe them as kind of ongoing, but in very good shape.
Thanks, Ray. Nothing to add. I think that covers it. Appreciate, as always, the collaboration with your team as we review FY21 and work towards FY22, but agree with everything you said and nothing substantively to add.
Great, thank you.
Ray, could you remind the council on when there is a hearing on the budget? I believe we have to have one sometime in the spring.
Yes, excellent point. That's right. Statutorily, CHIA is required to have an annual meeting on its budget. That has been scheduled, and I want to say that it's in May. I don't know if Alex or Emma or Andrew, if anybody is able to unmute and remind us of the date, but that has been scheduled. Faye, we'll get, or somebody can chat me or text me, and I'll let everyone know. But that has been scheduled. We do appreciate the participation of the Oversight Council on that because it is a statutory requirement of CHIA's.
Thank you.
Okay, next slide. Or are there any other questions? Okay, next slide, please. I won't read through each of these, but just briefly, I put this up to remind folks that in addition to all of the work, CHIA's kind of legacy work, if you will, and new work that we've taken on, for instance, the health reform bill that passed in December. You'll hear a bit more about that soon. CHIA continues to do a significant amount of work to support the state's COVID response, and that falls into a couple of different categories. We've boosted our data collection efforts. You see the specifics on the slide. We've also increased the frequency of our reports, and this is very important. The three areas are enrollment trends. That's something you want to monitor very carefully when there's a significant economic disruption, such as there has been with the pandemic. We've been monitoring hospital and health system finances very closely, which once again, that's something that's been very important because of the pandemic. And then lastly, we've accelerated our reporting on hospital inpatient discharges, which is an area of the health system we have particularly good visibility into. It's an area that was particularly impacted by COVID, and so we've accelerated our reporting in that area. And then we're doing some additional things for the command center that are somewhat outside of our core responsibilities, but where we have some skill set that can lend a hand with the work that's being done. So there's a few of those listed. But this hasn't changed substantially in the last 3 months, so I won't go into it in any more details than that unless there are any questions about the work we're doing for the command center. All right. I will say we did get an inquiry reach. We're having some discussions on possibly lending a hand with some data collection around vaccination, and not in it's sort of a fairly tangential way. It's not the core stuff, which is very well, kind of CHIA is not involved in that, and that's very sort of big, complex, and very well under control. There is sort of an incidental collection activity that CHIA might get involved in. That would be our first involvement in the vaccination aspect of the pandemic. So anyway, if that actually comes to pass, we'll have more to say, at the June meeting. So those are our command center related activities. Any other questions or comments on that? Okay, if we could go to the next slide then, Alex. Okay, this is just a placeholder slide really to remind folks that we will be doing an update in June on, so the June meeting will also be a very full one. We'll be doing an update on our enhanced APCD project. It has been, I think originally I was expecting that it would reach a certain point at which enough had been built and enough had been done that it would just be like dominoes falling, that it would sort of become very easy from that point to the finish line. It has certainly defied that expectation. This has been a heavy lift kind of from the beginning, but the CHIA team has done really remarkable work. And frankly, our partners at IBM have met that effort with sort of a very heavy level of effort on their part. And we're coming into the finish line, and it's really, really exciting. And so you'll see in June, we're operating the system now with huge amounts of data in it, so we have a sense of its responsiveness and whether the numbers tie out to the way we used to do it in the sort of the old-fashioned approach. But everything is checking out. So we're nearing the finish line. It's looking very good. And what we'll do in June is have an actual live demo and by Deb Scheel, who's been heading up our effort, and we can go into it in a lot more detail. But as you can see, what we've got, and that, screenshots aren't really worth a whole lot. And all this is just a picture of the user interface. But prior to what we're getting ready to unveil, or what we're actually currently using, accessing the APCD was, it required one of our, 2 or 3 gurus to write code that would extract data that had to go through an extensive QA process before it could be turned over to analysts. This is going to allow the analysts to kind of natively access our claims data repository. And in order for that to happen, you had to engineer a huge amount of intelligence into the system, because this is a very complex data set that comes from many, many different sources. And knitting that together and making it all tie out is really quite an exercise. So the team has done a remarkable job. I think we're close enough to the finish line to feel very, very good about where this is going to end up. And so in June, we'll be doing a presentation on the APCD project. So I don't know if there's any questions, just before we move on. Like I said, this is only just a placeholder, but we're excited about where we're at. I know in the past, some folks have mentioned there are press reports about, there have been reports in the press about IBM and kind of their healthcare division. I can say that we've received, first of all, the level of effort and commitment that has been clear to the project has been extremely impressive and really allays any concerns we would have. And also kind of the representations we've received from our partners have also been very encouraging. So we continue to work really hard. We're very near the finish line, and yeah, we're looking forward to showing you this in June.
I think you have a question for Meredith.
Great, thanks, Faye. I was just wondering if you could remind us, Ray, what the timeline is in terms of the rollout to internal stakeholders like DPH and the rollout to folks like me.
Let me think. So I know that
precise about it.
I think, well, internal, we're in user acceptance testing because we have enough of the system that we've received that it's actually, we're pressure testing it and kind of running the system right now. And I know there are people from the HPC involved in that effort. And DPH is so busy because of the pandemic response. I think we want them involved, but their involvement may still be to come. So internal stakeholders are already, pressure testing the system with us. When it will be generally available to researchers is definitely a bit further down the road in terms of, I think we have to get through probably this calendar year, just sorting out, getting the system up and fully running, and internal users, and all the enhancements won't even be in place until a bit later in the year. So I think before we would open it to externals, it would be a longer wait, but we probably should be perhaps tapping a couple of folks such as yourself to start exploring those issues and seeing what's involved in taking that next step.
Yeah, I guess I was also curious whether in this in-between zone, you're going to be releasing data for 2019, you're the old-fashioned way? Yes.
I mean, well, and by the old-fashioned way, actually, I think by a more efficient process. We're using this as an opportunity to improve the way we do APCD releases. So you'll actually see improvements. It should be faster with more data, and that will continue uninterrupted. But we actually have hopes that eventually researchers would be able to, all the richness of the system, actually the enhancements that are being added to it, you would benefit from in terms of a data request. You could request those enhanced fields like DRGs, for instance. That's not something we used to be able to put on claims. Now we will be able to, or we will be able to when this is fully stood up. So that's the type of thing that a researcher would benefit from via the old extraction methods, but relatively soon.
Got it. Thank you.
You're welcome. All right, any other questions about the APCD project? Okay, then why don't we move on? Alex, next slide, please. Okay, at this point, I'm going to turn things over to Emma Schlitzer. CHIA's External Affairs Manager. She's going to be talking about some of our recent and our upcoming publications and data releases. And I will say, one of the things we're thinking about and working on internally, in addition to the analytic agenda that we'll talk about in just a little bit, is some communication strategy, because we're producing so much material, so much information that I think it's really hard for anyone, even the most dedicated CHIA fans, to keep up with it. So I think we're going to put our heads together to see what we can do to simplify it for people, because it's a lot of volume of really good data and analyses. So let me turn it over to Emma for her to show you some of what we've been doing. So I'll hand it off to you, Emma.
Thanks so much, Ray. I also just want to quickly note that the budget hearing is scheduled for Monday, May 17th, just so everyone is aware. But like Ray said, I'm going to quickly go over publications that have been released since our last council meeting in December, and then look ahead to what's coming next. If you could go to the next slide, Alex. Great, thank you. So as you all are aware, last week, CHIA released our annual report on the performance of the Massachusetts healthcare system at HBC's benchmark modification hearing. I won't spend too much time here since we'll be hearing a lot about this later on today. We have also released hospital inpatient discharge case mix data for FY19. That was a new publication. We have also continued to do health insurance enrollment reporting, both on a monthly cadence with the monthly enrollment monitoring reports and our usual biannual enrollment trends report. We have also continued to publish quarterly reports on hospital and health system financial performance. The most recent of those had data through September 30th, 2020. We also recently released FY19 Massachusetts Hospital Profiles Report. This third bullet item is a new series that we launched titled An Inside Look, Affordability Findings from the Massachusetts Health Insurance Survey, also known as the MHIS. We have been releasing 2 of these research notes monthly, and 4 have been published so far. We are also very excited to launch a CHIA newsletter titled Data Matters. That inaugural edition went out early this month, and we have also released FY19 outpatient observation case mix data. So looking ahead to what's coming up next, we will have the last 2 research briefs in our Inside Look series. Those will likely be coming this month. We will also continue to publish monthly enrollment monitoring, again on a monthly cadence. And then we are doing our first quarterly update to the hospital inpatient discharge case mix data. We're very excited about that. We'll have data through the end of 2020. We will also be continuing to publish on hospital and health system financial performance. A new report that will be coming out soon is a preliminary hospital fiscal year 2020 hospital financial performance report. This represents one of the publications that we've expedited that Ray touched on earlier. Typically, this data isn't released until the summer. As Faye noted earlier as well, we will be releasing data on relative price and provider price variation for 2019. And also hospital emergency department discharge case mix data for FY19. We are also starting a new research brief or releasing a new research brief on unmet social needs that utilizes data from the MHIS and plan to also release national healthcare data statistics. So lastly, the next edition of Data Matters will be coming out in May, and then we will also be releasing release 9.0 of the APCD. So I know that was a lot of information. As Ray noted, there have been a lot of publications, so I will pause in case there are any questions.
Also a lot of work. Thank you. And I really like the newsletter. I think that's wonderful, getting people to understand what CHIA does and the resources that are available.
Great, thank you.
You.
Hear it. If there aren't any more questions, I think we can go to the next slide, Alex. Great. So I will be providing a quick legislative update since our last meeting. As most of you are probably aware, Governor Baker signed an act promoting a resilient healthcare system that puts patients first on January 1st, 2021. Just a quick overview, very high level of what's contained in that bill. It includes telehealth coverage, specifically permanent rate parity for telebehavioral health services. It also addresses surprise billing through enhanced notification requirements and balanced billing protections. And it also reduces some scope of practice restrictions for advanced practice nurses and optometrists. So moving to CHIA's involvement in this new healthcare law, CHIA is mentioned as a collaborator in 3 studies. The COVID-19 and telehealth studies will be led by the HPC, and the out-of-network billing study will be led by EHS. So we are in close contact with both agencies to provide data needed for those analyses. Next is that the law also calls for enhanced Medicaid payments to eligible hospitals. CHIA data is used to determine which hospitals are eligible, specifically our relative price data and our hospital financial performance data. And then lastly, the bill also calls for the HPC and CHIA to support DOI in establishing minimum standards for accreditation for certain telehealth services. So looking ahead to the current session that we're in, the 192nd General Court, at the beginning of session, we began tracking over 200 bills, largely related to healthcare. Out of that number, there are 85 bills that directly pertain to CHIA or have a direct impact on CHIA. A lot of those would add responsibilities that the agency currently has. And out of those 85, there's a wide range of topics. A lot of them pertain to healthcare cost transparency and cost containment, behavioral health and data reporting are a couple key themes. And then I also did want to note that we are also tracking about 80 mandated benefit bills. We track those because they have the potential to be referred to CHIA for mandated benefit reviews. So we will continue closely tracking these bills as they move through the legislative process this session. Are there any questions? All right, thank you. I'll hand it back to Ray.
Thanks, Emma, great job. I think that gives folks a pretty good sense of just the range and breadth of activities that CHIA is involved in and sort of how much work product we're producing. So Alex, if you could go to the next slide. And then one more. So this is also, I won't be going through this in any detail because we have to get on to the actual presentations for today, but Bill and others at the last meeting and for more than just one meeting have been asking for a discussion about CHIA's analytic agenda. And we've been, there's been a bunch of different things that have, when we were downsizing, that probably wasn't necessarily the right time. A year ago, as we were pivoting to remote work and trying to respond to the public health emergency, that probably wasn't the right time. But the truth is the last year has really helped CHIA, I think, sort out a lot of things. And there's been a subcommittee of senior leadership meeting to discuss the analytic agenda so that we can engage with the Oversight Council in a very meaningful discussion of this stuff. So this actually is not done. This is still at a midpoint. CHIA's senior team still has to have meetings to pressure test this framework. There's a lot more detail to it, but a subcommittee, as I said, has been working on it. And what we will do is this will be a topic of discussion at the, as I said, the crowded June meeting, and it can be discussed further. This doesn't have to be a one-time discussion, but this is a framework for taking all of the different things that CHIA does and trying to put it into a set of logical buckets. And it turns out this is something we need for, I think, for the Oversight Council, for it to be thinking about our analytic agenda. But as I was saying earlier, we're doing so much work that I think, even the people that want to know more about CHIA and engage more with us have a difficult time getting a grip on all the different things we do. So this is a framework that's intended to be externally focused. It's not, in some of the drafts were very technical. We started getting into techniques that we use and stuff. This is more intended to be something that helps the outside world understand the major categories of analytic activities that CHIA undertakes. So anyway, we'll be discussing this more in June, and actually we'll be sending out materials in advance of the meeting so that people can digest it for that discussion. But just wanted to let people know we've taken that to heart. There's been a lot of work that's been done. I think it'll be a really good discussion. But I think we've got some time if people have any quick questions about that process or any other aspect of this.
No, that's great, Ray. This is Bill. Very, very much look forward to it. Thank you for the good work and pulling that together.
Our pleasure. Right, we're looking forward to it very much as well. So, okay, well then I think the next item is to get on to the presentation of the annual report. So you see the very first item on this slide. Actually, Alex, stay on the slide for a second. And one of the things we discovered in doing this exercise is it's hard to come up with buckets that are mutually exclusive. Things tend to fall into more than one. But healthcare spending and utilization is something that CHIA focuses on very intensively, and you're about to see that with the annual report. So Alex, if you could maybe advance to the next, yes, that slide. I'm about to turn it over to Elisa Algren, Lauren Coakley, and Lauren Makashima to present CHIA's annual report. But just to put this report in context, as you saw when Emma was talking about our publications and our data releases, and as you will see more in June as we talk about this analytic agenda and this framework for understanding all the things we do, CHIA does lots of different things with lots of different data assets. The annual report is really a crown jewel. And so this is, historically, this is data that we collect starting in May, and that allows us to release the report in September. Last year, because of COVID, we decided to delay the collection of the data from May to September, and that has delayed the release of the report, to after the first of the year to where we are now. But the information in here, and as you also saw from Emma, CHIA has lots of data assets and analyses and reports that are very current, coming up through the end of December 2020. This is about 2019. The reason it takes, what's unique about this exercise, and we're the only state in the country that does it, is this: we assemble a picture of all the spending that happens in the healthcare system across all the sectors. So any state could give you an analysis of their Medicare spending, and any state could give you an analysis from their division of insurance of fully insured commercial spending. This puts it all together. This is commercial insurance, this is Medicaid, this is Medicare, this is VA, this is TRICARE, this is free care. This is all the spending that happens in the Massachusetts healthcare system put together and then sliced and diced in different ways to shed insights on what's happening in this healthcare system. That's an exercise that no other state does. It's really a wonderful tool for the policy community in Massachusetts to have to understand what's going on in our healthcare sector. So anyway, it's really good stuff, and let me turn it over. I don't know who's going to lead off the first part of the presentation, but let me hand it off to the CHIA team.
Hi, everyone. My name is Lauren Coakley. I'm going to be kicking us off here with presenting some of the top level numbers from the annual report, some of which I know some of you have already seen, but happy to answer questions at the end of our presentation. So we can go to the next slide, Alex. So here's a quick overview of what we're going to discuss today. So I'm going to start off with total healthcare expenditures. We'll move into Medicare, mass health, and then some of the more consumer side, so private commercial insurance trends. And then lastly, we'll address some of the quality pages in our report. So next slide, thank you. So starting with the top level total healthcare expenditures, or THCE numbers, total healthcare expenditures totaled $64.1 billion in 2019, which equates to $9,294 per capita and a growth rate of 4.3%. And next slide. And this slide shows the growth rates from 2013 to the present. So obviously we are above the healthcare cost growth benchmark in 2019. And I think it's also important to note here that the final 2017 to 2018 growth rate was revised to 3.6%. So also in excess of the benchmark. And we'll kind of dive into the different portions of THCE and what we think is happening here. So looking at the overarching components of THCE, we saw growth in all categories except for the net cost of private health insurance, which is NCPHI, which is essentially the cost associated with administering healthcare. The highest growth we saw was in commercial, where we saw a 5.7% increase in spending in 2019. But as I said, we also saw increases in Medicare, mass health, and other public programs, which includes the VA and the health safety net. So this year's report breaks out THCE spending by service category, both gross and net of prescription drug rebates. So I'm going to first discuss this chart, which is displaying pharmacy gross of rebates. So from 2019 to 2018, we saw expenditures increase across all major service categories. So all the service categories you see in blue here, which are hospital services, pharmacy, and physician. with the highest growth in pharmacy, which increased 7.2% from 2018 to 2019. We only saw a decrease in other medical spending, which includes skilled nursing, home health services, and durable medical equipment, among other things. That was the only service category that we saw a decrease in spend. And this next slide displays the pharmacy spending net of rebates. Everything else is the same on this chart, but net of pharmacy rebates, pharmacy spending increased 3% from 2018 to 2019, falling behind the other major service categories in terms of growth rate. And net of rebates, hospital outpatient experienced the fastest growth among the major service categories, increasing 6.3% from 2018 to 2019. And as you can see here, hospital inpatient also grew 3.8% and physician spending increased 4.3%. So moving into the Medicare portion of the report. So Medicare expenditures totaled $19.2 billion in 2019, which was an increase of 5.2% from the previous year. And during this period, we also saw enrollment increase by 2.5%. And this next slide breaks out Medicare into fee-for-service versus Medicare Advantage. So as in previous years, we saw expenditures grow faster for Medicare Advantage beneficiaries than for fee-for-service, in part due to increasing enrollment. So Medicare Advantage spending increased 8.4% from 2018 to 2019, and fee-for-service increased 4.8%. And now to the Mass Health portion. So Mass Health spending totaled $15.7 billion in 2019, which was a 2.8% increase from the previous year, during which we saw a dip in enrollment of 2.9%. This next slide breaks out the Mass Health spending by program type. So we saw the biggest increase in expenditures for the ACOB and programs for the dually eligible, so SCO, PACE, OneCare. And in these programs, we also saw a significant increase in enrollment. We saw decreases in fee-for-service spending, ACOA, and PCC plans. And as I said, overall spending increased 2.8%. And this slide addresses and goes into the alternative payment method section of the report. So as we saw last year with the implementation of the ACO program in 2018, Mass Health APM adoption continued to grow significantly in 2019, with 84.6% of members reporting APM use. We did not see much of a change in commercial APM adoption. It remained pretty stagnant, as we've seen in the past few years. And Medicare Advantage APM use decreased slightly in 2019. And finally, getting into the commercial portion of THCE. So commercial expenditures totaled $24.9 billion in 2019, which was an increase of 5.7% from 2018. And we saw membership grow less than 0.5 percentage point during this period. And looking at it by product type, we saw the biggest increase in spending in the HMO product type, increasing by 11.6% from 2018 to 2019, during which membership also increased. The only product type that we saw a decrease in spending was in POS, and we also saw a decrease in enrollment in that product type. And I will turn it over to Lauren Makashima, who's going to talk a little bit more about the consumer side of commercial insurance.
Thanks, Lauren, and good afternoon to the council. So diving deeper into commercial insurance spending, there are several plan designs that are aimed at lowering healthcare costs by encouraging consumers to either select high-value healthcare or stay within networks where the cost of care can be managed more efficiently. CHIA asks payers to report enrollment in 3 of these benefit designs: high deductible health plans, tiered networks, and limited networks. As you can see from the slide, enrollment in tiered and limited network products has largely stalled. And in 2019, about 19% of commercial members were enrolled in tiered network products, while just under 6% were enrolled in limited network plans. The only strategy where we've seen really broad adoption in the market is high deductible health plans. Enrollment has increased every year since we started collecting this data. And by 2019, 35% of commercial members were enrolled in a high deductible health plan. Next slide, please.
I'm sorry, this is Faye. I'm not sure I understand the difference between a tiered network and a limited. Aren't they simply smaller networks?
Sure. So with a tiered network plan, the provider networks are segmented with differential cost sharing. So for example, if you saw one provider, your copay may be $25 versus if you saw a provider belonging to a different network, your copay may be $50.
Right.
With the limited network health plans, there's no tiering within the network, but the total number of providers is limited.
Okay, but you still go to those and you get better coverage.
Yeah, so those are the ones that are covered by your insurance versus the other ones may be considered out of network.
Got it. Okay, thank you.
Yeah, no problem. All right, so just focusing down further on just the high deductible health plan enrollment. We've found that enrollment is not evenly distributed across the market. And in fact, enrollment correlates pretty closely with group size. So this graph shows the prevalence of high deductible health plans in each market sector. So we see unsubsidized individual plans up at the top, and then employer-sponsored insurance ranked by employer size with the largest employer groups at the bottom. We can see that 85% of unsubsidized individual purchasers and more than 60% of small and mid-sized group members with 100 or fewer employees are enrolled in high deductible health plans. Prevalence of these plans is also rising across nearly all market sectors. And the fastest growth from 2018 to 2019 was actually for members covered by jumbo group employers with 500 or more employees, which increased from 25% of members in 2018 to 30% of members in 2019. And we think that these findings are really significant because of the impacts that high deductible health plans have on cost sharing and affordability. CHIA's recent affordability brief on high deductible health plans, which Emma mentioned earlier, that brief was based on household survey data from 2019. And they found that 31% of commercially insured respondents with high deductible health plans reported an unmet need for healthcare due to cost, compared to 19% of respondents with non-high deductible health plans. Next slide, please. So in this slide, we're looking at cost sharing, which includes copays, coinsurance, and deductibles paid for medical and pharmacy services. Unsurprisingly, given the high deductible trends, cost sharing continued to be the highest for unsubsidized individual purchasers, as well as members covered through smaller employers. In addition to having the highest cost sharing levels, individuals and small group members also experienced high cost sharing growth in 2019, upwards of 7%, which is in the range of what we've seen in previous years. While the members covered by larger employers, closer to the bottom of the graph, experienced slower growth or even stable cost sharing compared to the prior year. Because most members are covered through these larger employer plans, the market average trend was plus 2.8% in 2019, down at the bottom in orange, and that was much slower than in the prior year at 6.3%. But despite the low average growth, we shouldn't overlook the fact that high deductible health plans leave members more exposed to high increases in healthcare costs, which may explain the differing trends we saw across the market sectors. Next slide, please. All right, so this slide reports premium trends for the 40% of commercial members with fully insured coverage. On the previous slide, we saw a cost sharing deceleration that was only experienced by enrollees of larger employer plans, but premiums are a little bit of a different story. In 2019, premium growth slowed in every market sector. Unsubsidized individual purchasers actually experienced a 1.1% premium decrease, which is pretty unusual. We think that there were two drivers of this trend. First, we saw enrollment shifting into plans with the lowest premiums, which were offered by Tufts Health public plans. By 2019, 42% of unsubsidized individual purchasers were enrolled by Tufts Health Public Plans. Second, this market sector had the greatest decrease in benefit levels in both 2018 and 2019, suggesting that some members have migrated to plans with higher cost sharing in order to keep their premiums lower. The market average premium trend was plus 2.2% in 2019, so that orange bar at the bottom, and that was compared to 5.7% growth in the previous year. Next slide. Thank you. So we heard earlier that commercial healthcare spending accelerated in 2019, and we've just seen that premium growth slowed. These two trends impacted premium retention, which is the portion of premium dollars that go towards plan administration, taxes, and basically anything other than medical services. So in this graph, the total length of each bar is the average premium for the year. The gray segments are healthcare claims that plans were responsible for, and the various blue segments together make up premium retention. So the top cluster of bars represents the merged market, and you can see that in 2017, 87.8% of premium funds went towards medical claims and 12.2% were retained. Premium retention rose to 13.8% of premiums in 2018 and then declined to 11.5% in 2019. In the merged market, which is the most tightly regulated commercial market segment, margins are pretty slim. After paying taxes, broker commissions, and other expenses, payers netted less than $2 per member per month in 2018. And in 2019, when retention declined, they actually lost $6 per member per month on average. In the large group market, which is that middle cluster of bars, premium retention also decreased from 13.1% of premiums in 2018 to 12.3% of premiums in 2019. However, gains were more stable in this segment of the market, and on average, payers reported gains of $11 per member per month in 2018 and $10 per member per month in 2019. And of course, these are averages, but different payers had a range of experiences in these market segments, and different payers also participated in different parts of the market. And the final thing I'll say on this slide is that these percentages are not the same as medical loss ratios. On average, the merged market MLR threshold, which is set at 88%, was met and exceeded in each reporting year from 2017 to 2019. And the annual report includes a 3-page explainer that outlines the differences between these metrics, as well as reports on the average merged market MLRs for each of the 3 years. Next slide, please. Okay, so this graph pulls together some of the financial trends from the previous slides and puts them into context. So between 2017 and 2019, cost sharing, which is the dark blue bar, the dark blue line at the top, grew 9.2%, and premiums in orange grew 8%. Wages and salaries didn't keep up at about 6% growth over the 3-year period. The light blue line reflects claims covered by insurance as well as self-insured employers. So what's interesting here is that at the 2018 midpoint, the percentage increase for premiums was much higher than the one for claims. But by 2019, those two metrics were approximately equal. And if we were looking only at fully insured claims, we would see that those exceeded the 2-year growth rate of fully insured premiums. And that's why we saw fully insured premium retention decrease from 2018 to 2019 on the previous slide. So we really see, we think that this is an expected part of the health insurance underwriting cycle. Health plan actuaries do their best to project future costs given the data that's available to them. But in some years, premiums will grow faster than claims, and in others, they'll grow more slowly. So to sum this up, in addition to the high overall THCE growth and being above the benchmark 2 years in a row, we also see some concerns around affordability. This is an area that CHIA will continue to monitor in the future, along with, of course, analyzing everything else that has happened to the healthcare system in 2020. Finally, I'm going to hand it over to Lisa Algren, and she's going to talk about quality of care.
Thank you, Lauren, and good afternoon, everyone. Haven't discussed the quality chapter of the annual report here in previous years. I wanted to give a general overview of what's included in the and note some new metrics that we added here. The charts in this chapter include experience data. So we report experience data following acute hospital admission, which is collected CMS via the HCAP survey, as well as primary patient experience surveys by Massachusetts Quality Partners, or MHQP. And MHQP has fielded the survey in the commercial population for many years among members in HMO and POS plans. And in 2019, Mass Health worked with MHQP to distribute the first survey to Mass Health ACO members. And this report includes findings from that first survey, which established baseline scores for services in 2018. And I'll highlight those results more in a moment. The chapter also highlights readmissions findings that CHIA's strategy and research team have reported from the hospital inpatient discharge database, which this year includes some new behavioral health comorbidity findings, as well as overall statewide readmissions trends. And finally, we include several metrics from the Leapfrog Group Hospital Survey, which hospitals submit on a voluntary basis. We have reported on some of them, such as key maternity measures for several years now, but a couple new ones this year, measures of antibiotic stewardship and medication reconciliation, and a score for adherence to National Quality Forum safe practices. As I'm sure many of you are aware, quality measures tend to tend to move very slowly. So the changes over time from year to year are slight, but of course they're important to monitor. We're highlighting this year's chapter more than in previous years because, like in every other sector of healthcare system reporting, we expect to see notable shifts in next year's report, which will include data either representing 2020 or collected during 2020. I know that some data collection halted entirely and several adjustments were made to scoring and reporting a burden during response to the COVID-19 pandemic. So I think we'll be referring back to the data points in this year's chapter often in future reporting as a baseline to assess the impact both on quality measure scores themselves and on the level of burden to maintain the requirement of quality reporting. So with that context and general overview, we can move to the next slide, please, Alex. Thank you.
I hadn't heard that before. Excellent context, Lisa. Thank you.
Thank you. So I'd like to share a couple of our new charts with you. This chart highlights statewide level results of the baseline Mass Health Primary Care Patient Experience Survey for adults. The sample includes members for all 17 Mass Health ACOs who had a primary care visit in 2018. And as in the commercial population, which I'm not presenting today, but is in the report, communication is the highest scoring domain, and behavioral health and self-management support are the lowest scoring domains. And because I often get asked what self-management support is, I'll just mention that this measure refers to whether the provider talked with the patient about specific health goals and asked about things that make it hard to take care of their health. You can see Mass Health has established threshold performance minimums and goal scores for a subset of 4 domains, and scores exceeded the minimum for all 4. And we can go to the next slide, please. Thank you. And we can see on this slide that scores for pediatric patient experience surveys were generally higher than for adults and highest in the communication domains, lowest in self-management support. So these are trends that again mirror the overall trends in the commercial population. Statewide scores were very close to the goals established, and in the case of willingness to recommend the provider, even slightly surpassed the goal. I'll also note here that MHQP did not circulate a commercial patient experience survey in 2020. And at the time that we were pulling the data together for this report, Mass Health was still assessing the impact of the fact that theirs was circulating among members during early February through May, which is a later end date than planned because of lower response rates. So this is certainly an example of quality reporting that will be extra challenging to capture and contextualize in next year's annual report. So thank you, that's all I have for today, and we're happy to answer any questions for either Lauren or myself that you might have.
Great, thank you.
I have a question. I thought the report was really well done. And also there's the way you summarize the statistics and everything. So fantastic job. Who do we envision is going to make the most use of this report? And what types of maybe decisions or insights do we think they're going to get out of it?
I mean, I would say this is fundamentally focused on the state's kind of policy, the policymaker community, and I think that's primarily public sector. So I mean, I think the immediate sort of a lot of our work, the HPC is kind of the logical successor to it, but I think it provides the context for legislation. I mean, I think the legislature, as they're looking at, and we have a magnificent healthcare system in the state, and the legislature is active in healthcare policy. So I think creating that factual foundation for the public sector healthcare policy making is crucial. But then I also think this data is used by market participants in the healthcare sector to understand, various aspects of their environment. So I guess it's concentric rings, but I think of this first and foremost as a tool for policymakers to understand the system better. But I don't know, David, if you have, not to put you on the spot, but do you have, other thoughts on, but I think of this fundamentally as a public sector policymaking tool or something to support that.
Yeah, I completely agree, Ray. And, last week we were able to have a public meeting and presentation on the report with the Joint Committee on Healthcare Financing, who are thinking about their legislative agenda. We at the Health Policy Commission have a decision about where to set the healthcare cost growth benchmark. And this data helps inform that important policy decision. And really understanding the drivers of what is driving healthcare costs, I think, is just a critically important question. And so we can look at areas like hospital outpatient spending, which was a category that had high growth, and try to understand what is driving that. Is there more use, more utilization? Is it price growth? Is it shifting patient care between lower price providers to higher price providers? And I think allows many of us to be able to do that deeper dive to answer the questions about where are those opportunities to be able to get our healthcare cost growth back under the benchmark, and doing so in a way that doesn't compromise quality or access. The kind of bigger concentric circle to all of this is that there are now many other states that are pursuing the concept of a total healthcare cost growth benchmark, and are deeply engaged in understanding how Massachusetts is doing this work. And so the work of CHIA not only informs policymaking in Massachusetts, but really across the country, because so many other states are thinking about how to measure healthcare costs, to set targets, and we're just such a leader in that respect.
Thank you, David.
Great work. Great work.
Rob?
Oh, thanks, Ray. Yeah, sorry. I had a quick question about the high deductible plan increases that are being seen. I know, Lauren, I think you mentioned that, that's some of that is being driven by consumer choice. But I was wondering, is there like a potential confounding variable where like those are just the plans that are being offered by like the smaller mid-range businesses, or if we have any like survey data or anything to explore that?
Yeah, absolutely. So we know that enrollment is sort of a factor of both employer offering as well as uptake. And our employer survey dives into this a bit. I think the other piece that I didn't have a chance to mention yet is that we know that some larger employers also offer health reimbursement accounts or health savings accounts, which are tax advantaged in order to help employees cover the cost of those high deductibles. And we know that employees at larger employers are more likely to have access to those products. So both of those issues are covered in the Massachusetts employer survey data that CHIA produces.
Awesome, thank you.
Yeah.
I would also share just thoughts from the DOI perspective that from the plans that we review, especially I guess in the merged market, that there is a wide variety of plans that are offered in the merged market. From a metallic tier basis, they range from platinum down to bronze, and the higher in or the
the lower you go in terms of the metallic tier, so if you're going towards from platinum down to bronze, you're more likely to encounter the higher deductible the higher deductibles within the product. And but also you're going to see lower premiums when you go from platinum towards bronze. And so if you're an employer looking at the variety of products that are out there, if you're looking to keep the premiums lower, you may be more likely to be choosing a bronze plan that has a lower premium but a higher deductible.
That's a really interesting point, Niels, because I had been thinking of this as a consumer choice issue, that consumers are gravitating towards the lower premiums, which is certainly, I think an element of this. But for employers, that there's at least an implicit bargain where they're covering a percentage, then the lower premiums of a high deductible health plan are particularly appealing to them, because then none of the cost share. So there's just an alignment of interest both on the employers and the individuals at the premium level to want to move towards these types of plans. But as we saw in the report, kind of the total cost of ownership is different than just the upfront premium experience.
Does it also say it must be easier to throw a deductible on than to tell people which providers they can go to? I was interested in that, where the people were moving.
Right.
That's my conclusion from having studied it too, is throwing a deductible in is really simple and it's guaranteed to save money. Tiered networks, much more complicated, and the savings are much less.
Yes, and people really hate them.
People hate a lot of this.
That's true. Although I thought it was interesting, 70% on the survey, and I think you mentioned it, I can't remember, Lauren, was you or not, said that they didn't have trouble with the high deductible plan that year. They did fine.
70% of people almost never go to the doctor.
Exactly. So for them, this is a really good economic decision. I have a question, I think more for you, Niels. Is there a pressure more toward employers doing self-funding ASO type of plans to reduce their costs? Is that pool growing at all?
I'm not quite sure what you're asking. Are you saying that they're
fully insured to self-insured?
Pressure to go towards being self-funded?
Yeah.
I
mean, you can reduce your cost.
I'm not sure that we've seen that trend. I think it's definitely mixed. I think the numbers that we've seen have been relatively stable in that.
Interesting. I'm seeing a lot more marketing of self-insurance to what I consider smaller employers and worrisome.
Just to build off that, I think that is a question that I had for maybe the CHIA team, because I think, a few years ago, we were starting to see a real shift to PPO plans, but I think from some of the data in the report, it seems like that has not continued and has stabilized, but wondering if maybe your analysts could speak to that point.
CHIA team?
Yeah, I do agree. I think a few years ago we were seeing more PPO membership than we have in the past few years. And like I said, we did see a 3.1% decrease in membership in PPOs between 2018 and 2019. So I think we could look more into what may be driving that specifically, but I agree that the trend has kind of reversed and gone back into the HMO growth over the past 2 years or so.
Thank you.
Thank you. No, it's really very good work. Thank you all.
I was just wondering, building on this conversation about the report's analysis of the high deductible plan growth, whether there's any consideration on CHIA's side of building in some additional questions into the health insurance survey the next time that's sent out to try to tease out some of the factors that drive the decision to move into a high deductible plan, just because it seems like the implications are quite different, right? If it's someone whose employer has changed the offerings available to them versus someone who is eager to take advantage of benefits associated with a tax-advantaged HSA versus someone who predicts low utilization for themselves and their families and sees this as a cost-saving opportunity. or someone who says, look, I can't afford the premiums, so I'm going to go to the cheapest plan possible, and is likely at risk of not being able to meet that deductible and foregoing care. It would be really interesting to see a breakout of how those factors are driving the trends that you're reporting. And I think that the CHIA survey would be a really interesting way to dig in.
I think, let me ask the team to what they know about it. I know just at a high level, the household survey is something that, and we started doing recontact surveys where once we find out a population in the survey of people that experience a particular issue, we circle back to them so we can get a deeper dive. And it doesn't have to be particular to affordability. For instance, the Betsy Lehman Center did some really interesting work doing recontact surveys of people that had experienced serious medical error. But I know that in recent cycles, we've been focusing specifically on affordability, not high deductible health plans per se, but I know that more work has been done and is being done. And so let me turn it back to Lauren or Lisa, whoever can speak to this particular issue. Do you know what the current status is of our enhanced sort of reporting in this area off of the survey?
So a couple areas that I can point to, first of all, would be within the employer survey. We do survey employers about what factors are most important to them when selecting a health plan to offer to their employees. So I would point to that first, but definitely we can take this feedback back to our research team. I think this will definitely be an area of lots of interest in the coming years.
And yes, we'd be happy to talk off. I mean, it's definitely an area of significant interest. And so we can include others, as that are interested from other agencies or the Oversight Council in those discussions. Other questions or comments on the annual report? I mean, I would say, the fact that the cost growth exceeded the benchmark is probably headline number one. And then the continued really rapid adoption of high deductible health plans is the second major headline to come out of it. And just the implications that has for our system. CHIA has a statutory obligation to have a consumer transparency website, the premise of which is that we should support people in shopping for procedures. I think that actually the wide adoption of high deductible health plans puts a premium on understanding the cost of procedures, although I think sort of working with your health plan is the best way to get at that information. But there's a question around whether we should be helping people just as we're giving them tools to shop for procedures. Maybe we should give them tools to shop for insurance so they can understand the total cost of ownership, because it's not just the premium, it's the full cost. And we don't know, but I think it's certainly possible that people are choosing products that aren't ultimately in their long run best economic interest, but it seems to be the less expensive alternative up front. So I think that understanding how and why people are making these decisions, how and why employers and individuals, is definitely an area for CHIA to continue doing some work.
Or could it be the reverse? And I guess it's more of an insurance question of all the people that are healthy are going to pick large deductibles, which is great, except it lowers the pool for the high risk. So it's balancing it. It gets back to that underwriting and actuarial question. But if you're 20 something and you're buying it, why would you? Yeah. So anyway, I don't make the assumption that it's just stupid people. I think sometimes consumers are actually very, very smart, and they can figure it out.
True. Although, but the survey, our work on affordability suggests, and Lauren, somebody remind me, I thought the number 52% stuck out as the percentage of people in high deductible health plans that didn't seek medical care because of a cost concern was 52%. And we're talking pre-COVID, where there was a lot of, sort of avoided care. So
but you make the assumption that was the right answer. I mean, the wrong answer. Maybe it was the right answer.
Well, that's true. I guess, yeah.
I just don't know. I think it's really an interesting question. But the whole idea was, I think about it and decide whether or not this is worthwhile.
True. That is the premise, is that to get people to think. Right.
But great questions. This is really important work.
Lauren, did you have something you were going to be?
Yeah, just to follow up on that figure. So the 52% were those who had any affordability issue in the prior 12 months. So 52% of those who were enrolled in high deductible health plans, compared to 39% of those who were not enrolled in high deductible health plans had an affordability issue within the prior 12 months. And then the figure that I mentioned during the presentation was that 31% of high deductible health plan enrollees had an unmet healthcare need.
I conflated those two. Thank you. That's
Thank you.
good. Good to have.
And other affordability issues measured included medical debt, not being able to pay medical bills. So I think this is more than just people deciding that they didn't need the care. These are causing real affordability.
Okay, so that's a different question. Yeah, thank you, David. Yeah.
I just wanted to add, Ray, just to kind of your headline summary points. While we did go over the benchmark in the most recent year, 2019 measured, according to our research, we're still below the US growth rate and have been since the benchmark was established. And, you know, I do think it's an interesting kind of mixed story where we exceeded the benchmark in 2019, but premium growth and cost sharing growth on market average were actually below the benchmark at 2.2 and 2.8% growth, respectively, with some variation that you guys noted underneath. But it is kind of it's a hard story to tell, and I think you've been doing a really nice job in trying to put all the pieces together.
Yeah. Yes.
Well, thank you. Although I should emphasize that really it's we're just kind of establishing some initial facts, and then really it's the HPC that does kind of the really deep analysis of, you know, what these things mean. I mean, I think we want to make sure that we've provisioned the data for a really good discussion. But you're right. So the headline number doesn't, you can easily jump to conclusions just seeing the headline number, but we continue to be below national cost trend averages. And there's other context that it's different depending on the payer type that you slice it by. So it's very important, I think, to look at the full report and not, just gravitate towards that headline number.
It's complex.
Exactly.
Good segue, maybe.
And then I think another issue coming out of the report is that for a couple of years, we had seen premiums and cost sharing growing, or premiums growing faster than expenditures in the commercial market. And people were saying, what is happening there? And we expressed the belief that it was the underwriting cycle, that the way the health plans, it's a retrospective, or they're trying to predict the future using retrospective data, and that these things have a way of evening out over time. And that's another thing that this report seems to show, is that some of the trends we'd seen for the past few years in kind of the underwriting cycle have reversed themselves as we might have expected.
Yep.
Okay, well, are there other questions or comments about the annual report?
No, it's a terrific presentation. Thank you. Thank you, Lauren, and Aaron, and Lisa.
Yeah, it's a very global view of the system, which is really helpful. And, you can always dive in, but it's really nice to put all the pieces together and see them, kind of side by side. So great work, team. And I guess that now brings us to the next item on the agenda. All right. So I'm actually going to hand it off to David to do the introduction, because I think you can provide the context better than I can. But I know that we've got Uwe here to talk about the work that the Health Policy Commission has done on out-of-network billing. You heard Emma talk about the fact that this is something the legislature has directed EHS to look into as part of the recent health reform bill. So it's a topic that's been important for a while and continues to be important. And this again goes to the example of CHIA data, but then HPC further analysis. And so it's a repeating pattern. And so we're very pleased that they do this. And so Dave, take it away.
I think you set it up perfectly, Ray, and thank you for the opportunity to be able to present. So I'll just turn it over to Yua Huang, who is a senior research analyst at the HPC.
Great. Thanks, David. Thanks, Ray. Thanks for having me here today to share with you our work. Will someone share the slide on your end? Great. So we are talking about out-of-network billing in Massachusetts today, which is, of course, one of the many projects that we are able to accomplish with CHIA's data. Next slide. So with this audience, everyone will be very familiar to the concept of out-of-network billing, but I'll just give sort of a very brief, 3-sentence background. on out-of-network billing. So typically when a patient receives care from an in-network provider, the patient pays a cost-sharing amount based on their health plan, and the insurer pays the provider the negotiated price for the service the patient received. Now, when a patient receives care from an out-of-network provider, sometimes the insurer pays nothing. Sometimes they pay the full list price, or also known as the charge amount, and sometimes some amount in between. As a result, the patient may be required to pay whatever is left over. This is known as balance billing. Of course, out-of-network billing not only harms consumers because they're faced with this unexpected medical bill, but it also has implications on market functioning, leading to potentially higher spending and premiums. So at the HPC, we've been tracking this issue for several years. Here we listed a couple of publications that we have released on this topic. But today, what I'll show you specifically is a quantitative analysis that we published in May 2020, a chart pack looking at out-of-network billing in Massachusetts using CHIA's all-payer claims database. Next slide, please. So here, even though I'm using the term out-of-network billing, in this analysis, we really are talking about a very specific type of out-of-network billing situation that's colloquially known as surprise billing. As we know, sometimes patients do seek out-of-network care intentionally. They might see a physical therapist or a behavioral health specialist out-of-network. But really what we're talking about here is an out-of-network situation where patients didn't really have a choice. It could be an emergency where people needed an ambulance, or they go to the emergency room, or sometimes patients choose an in-network facility, but are seen unknowingly by an out-of-network provider. So for example, you go to an in-network facility for surgery and you were seen by an anesthesiologist that you didn't choose. So in this analysis, we're talking about, really the blue kind of bubbles in this graph: ambulance, emergency care, and a couple of specialties that happens outside of the emergency department that is prone to out-of-network billing. Okay, we can go to the next slide. So here we used the all-payer claims database version 7.0, 2017, and we were able to look at a pool of almost 660,000 commercially insured patients within this from 3 different payers. And within the sample, we identified 68,000 out-of-network claims that represented about 30,000 Massachusetts residents. And sometimes you would get one claim as part of kind of one interaction with the healthcare system. So on the encounter level, this represents about almost 45,000 cases where you very likely didn't choose the provider, but got an out-of-network bill. So within that 45,000 encounters, over 75% are from professional services. A little less than 25% were from the ambulance. Okay, we can go to the next one. So now let's look at each one of these. So within the analytic sample, we identified 21,000 ambulance encounters. Almost half of them resulted in at least one out-of-network claim. So that's the blue half of the circle here. And within these out-of-network ambulance encounters, the vast majority of them were for emergency transport, although there is a small share that were for non-emergency transport, less than 10%. These are for things like transportation to and from dialysis center. And And then there were 73 encounters that were for air ambulance or for somebody who needed a combination of air ambulance and ground ambulance transport. Okay, next slide, please. Okay, so now let's look at the professional services. So one out-of-network surprise billing situation we looked at here is emergency care. And again, that accounted for about 30% of the professional services out-of-network encounters. Half of these encounters were provided by emergency physicians. Radiology is next, and there were a mix of other specialists as well, internal medicine, pathology, and a few others.
So I'm sorry, just so I understand. So these are people who go to the emergency room in their network, their hospital is in their network, but then they see providers who aren't there.
These aren't
in the network.
So we can see on the claim that this claim is an out-of-network claim. I don't know if we could see whether the hospital whether the ED is in their network or not. I don't know if we could see that.
Okay, no, I'm just curious whether this is people who go to hospitals thinking it's in their network, and then the hospital is, but it never occurred to them that the, doctor wasn't.
Yeah.
Or whether they're going to an out-of-network hospital.
Yeah.
Minor detail. I just was trying to understand. You can go on.
No. Feel free to stop me and ask questions anytime. I don't think this is all in-network EDs. I think there's probably a mix of both.
Fine. Thank you.
Yeah.
And just really quickly, I think, Faye, the kind of the conceptual point there is that if you may not be in a position to make a choice when you're kind of seeking emergency care about whether you're going to in-network or out-of-network. So we're kind of where those out-of-network claims are occurring. So it's kind of less around the choice of the patient and more around where they're encountering it.
No, I got it. But so I'm sorry, I didn't mean to, but if I'm going to a hospital that is a network and the people who work in it aren't, or am I going to the whole group that's not, but you're not taking the hospital costs, you're just looking at the provider, the physician costs?
So these are just professional claims. We're not looking at.
So they could be, it doesn't matter, but I made me think about something, but I don't want to get us bogged down. My bad.
Oh, no worries. So these are just professional spending. I should have mentioned that earlier.
Yeah, no, that's what I figured. Yeah.
Okay, and then we can go to the next one. So outside of the ED, we know that out-of-network billing happens also when people choose an in-network facility, ahead of a visit or a procedure, but then they're, they're seen by somebody that they didn't actually choose. So these happens most frequently in these three specialties known as RAP: radiology, pathology, and anesthesiology. So we looked at these, the claims for these three specialties specifically and looked at where they were occurring. And for all three of these specialties, hospital outpatient setting was where most of the out-of-network encounters happened. For radiology, this accounted for over 80% of non-ED out-of-network radiology claims, 71% for pathology, and 66% for anesthesiology. Okay, we can go to the next one. And we know from literature that staff outsourcing is a leading source, a leading contributor to out-of-network billing. And we know that clinical outsourcing, it's generally appears to be increasing nationwide. So in the APCD, we were also able to look at the clinical organizations that build the highest volume of out-of-network claims in 2017 in these four specialty areas. So the bars here show the percentage of claims that were out-of-network among these provider organizations. And you can see that the percent does does vary, but for some of them, it is quite high. And there are a lot of different reasons why emergency departments and facilities might outsource their care. They might lack sufficient volume for certain services within a facility. They might lack professionals within a certain geographic area, so it just makes sense for them to outsource a particular specialty care to a group. But based on these numbers, it would seem that some of these independent specialty groups might have a business model where they don't contract with any insurers at all because 100% of their claims are out of network. Okay, and then next slide. So next, we looked at the issue of potential balance billing. Again, this is what happens when a patient is billed for the difference between the insurer's payment and the provider's charges. We found that sometimes the insurer is paid the entire charge in full. This happened in a little over 7% of the time, but the vast majority of the time, it looks like there is the potential for balance billing. And I use the word potential here because these are our claims data. We can't substantiate whether the patient did in fact receive a bill or not. But what we can see is that there is a difference between the full price of the bill and what the insurer and the patient paid. So that's what we're calling potential balance billing here. Next slide, please. So looking at these 90% of out-of-network professional claims with the potential for balance billing, how much is that average potential balance? It's about $167 per claim, but that is the average. It does vary quite a bit. At the 5th percentile, you have something as small as $5, but then at the 95th percentile, you have something as high as, $750. The amount also varies greatly by specialty, and with anesthesiology appearing to have the highest average potential balance. This is what is shown in the box and whisker plot at the bottom, and radiology having the lowest potential balance bill. Okay, next, please. And here we looked at the spending for a list of top out-of-network procedures. And we found that in the vast majority of cases, insurers paid more on average for out-of-network claims than they're in-network. So that's the dark blue portion of the bar. For the same procedure, the insurers are paying more when it's out of network than their negotiated price when it's in network. And despite the insurers paying more on these claims, patients still are potentially left with paying a substantial amount because of the higher charges on the out of network claims. In particular, the top two procedures are anesthesia procedures. You could see that out-of-network spending appears more than double the average in-network spending on the same procedures. So I'll stop there. There is a lot more in the chart pack, including more procedure codes if people wanted to look at the spending. We also have some specific ED analysis. And of course, as folks have said earlier, this is a policy area that remains highly relevant. So our plan is to update this work with 2018 data, and just always very grateful that we have CHIA and the APCD for giving us such insight and rich data to be able to look at this issue in a Massachusetts specific context. Yeah, I'll stop there. And
thanks, Yua. Yeah. Great presentation. And just to put an additional point on what you just said, I think this is a really good example of how much information is in this claims information and how we can mine it to really answer a lot of questions, because it starts with an out-of-network flag, but we're then able to map that to specific procedures and professional services that we're then able to map to the names of those providers and where that is occurring. And because we have allowed amounts and who's paying the allowed amounts and what the charge is, we know how much the insurer paid, how much the patient paid, how much was potentially left over. And then we can map that geographically. We can map that by patient zip code. And so the number of variables in the claims information just allows us to do this type of work that would otherwise not be possible with any other data source. Was that a good enough commercial for you, Ray?
I was going to say, that was perfect. The way both you and you ended that was like that. We couldn't have scripted it better. Yeah, that's exactly right. And I should say that one of the main purposes of the APCD enhancement project that we're undertaking is to make the data available to users like the HPC much faster, because a claim really is almost just a set of EDI codes. It's really, there's not a lot on the actual claim. To actually turn it into usable health information, there's quite a bit of expertise and transformations that are required. We're trying to automate an awful lot of that so that, frankly, the data is much faster from initial intake at CHIA to into the hands of analysts at CHIA and at the HPC. So we really appreciate the kind words, and we're glad that it's an important tool for you and that you use it, but we aspire to make it an even better tool for the important work that you're doing with it. So any questions on the out-of-network issue? It's definitely a current one. Well, actually, I do have one, which is that the federal government recently did something in this area, but refresh my recollection on what they did and how it intersects with what you've been looking at.
Do you want to take that one, David?
You can do it.
Oh, yeah. So there has been federal legislation on the patient protection. I would say mostly on the patient protection side of things, but we are certainly looking to update this data alongside UHSS and looking at. I think the main issue we're looking at is when patients are protected, how does the reimbursement work between the insurer and the provider? So that is an area that we are actively looking to have more analysis on using the APCD 8.0 2018 data.
Yeah, the policy question really is, once you make the decision to protect the patient from balanced billing, what is the appropriate rate of reimbursement to the provider for the services rendered? And the No Surprises Act federally leans on what has been pursued in some states of an arbitration model, whereby basically providers and the providers and the plans kind of in dispute do a baseball style, submit your best and final offer, and there's a process for adjudicating that. The federal act does allow for states to have their own set of rules for how out-of-network payments may be determined. And other states have taken different approaches, which rely not on an arbitration process, but on setting a default payment rate based on market averages or as a comparison to Medicare. There's a lot of details in the federal bill that have not been sorted out at all. It just got passed really at the end of last calendar year. And so still an opportunity for states to chart their own path.
Yeah, and certainly where the APCD comes in really handy is to be able to calculate some of these different benchmark rates, whether it's median averages, 130% over median or averages, is where the APCD will be really helpful in a state-specific context.
Right. I think some people have thought that the APCD sees everything, and it doesn't, because there's sort of a whole bunch of things aren't in there, self-insured claims and things like that. But if you're looking at payments moving back and forth between payers and providers, it's this gigantic sample size. And what you saw that for purposes of this analysis, the HPC was able to take hundreds of thousands or tens of thousands of episodes, and it creates these giant samples that you can work off of to do your analysis. So It's not a good tool for running totals, but it's an incredible tool for picking really any phenomenon in the healthcare system, getting a whole lot of encounters, and then doing a deeper dive.
So I have a question. If I'm a provider and I can get more money by not participating, why bother? Even if I don't bill the patient for the extra, I'm still ahead of the game. So are there providers that are getting a greater amount? Or are most of these providers from the insurance company, this is me not following, getting less?
I think you're picking up on the market failure that this entire topic illuminates, which is that there are some providers for which patients often have limited or no choice, depending on the circumstance, to pick in network versus out of network.
Right.
And those providers have a unique ability to not have to worry about a patient, kind of volume being steered by being in network and out of network. That's the advantage of being in network, is that you have volume steered to you. If you don't have to worry about your volume because patients aren't making that choice, why not go out of network? As you saw, some of those in one of the last graphs, the insurance company was paying more for those out of network claims, even without potential balance billing.
Right.
And so I think to the previous slide where we saw some providers who had very high rates of out of network billing, suggestive of a business practice that is trying to maximize revenue, that ultimately we all pay in the form of higher premiums.
Right. Yeah. And I think it's true. I don't know how you get around that. It's hard. I can see why the legislation doesn't come into the details yet.
Exactly. Well, and then there's the Massachusetts legislation that HHS will be heading up, which is to look at the issue further, kind of in the state-specific context.
Yeah, but anything that results in out of network getting paid more is problematic for the obvious reasons. So but you can't force them anyway. Good luck, guys. This is tough.
Definitely.
Other questions from council members? Other thoughts from you, Ray?
None come to mind, other than thank you for that wonderful presentation, Ewa and the HPC. We really are pleased to have such a close collaborative relationship between the two agencies. And we're looking forward to the June Oversight Council meeting. So I'll turn it back to you, Chair Donahue.
This is great, and I think a record in terms of going quick and through. We tend sometimes, for those of you who are new, Sandy, to hit the deadline at the end. I think next meeting in June will be focused in on the APCD and the analysis agenda. And that will be a little bit of a different meeting. I think there'll be much more conversation, particularly because one of the responsibilities of the council is to help set the analytic agenda. So look forward to that. And
very much so.
Everybody.
Yeah, no, great meeting, great set of presentations. Excited for where we started with the IBM rollout, Ray, as well. I think that's really nice work. Yeah.
Yeah, this is great. And you've done an incredible amount. It's just, you look at all the reports and all the activity that's going on. It's amazing. So thank you. It's good. And thank the team, especially. We know that it's, a lot of different people that go into making this successful.
Yeah.
Absolutely.
Thank you.
And everybody stay safe, stay well. See you in June. Except May 17th for some of you.
That's right, May 17th for some. All right. Do we need to do a motion to
adjourn?
Yeah.
I'm waiting for somebody to object to that. Hearing none.